Hi, it's Jonathan,
Hi, it's Amy.
and welcome to Cut to the Case. So Amy's here. So guess what? We're talking about ultrasound. And Amy, I've got a case. I've got an interesting case. I've got a look. Let's cut to the case. It's post-intubation hypoxia,
Right.
and let me talk you through it. So I've got a 65-year-old lady who's had pneumonia. She's failing with oxygen therapy. We've had to intubate her for respiratory failure from pneumonia. SATs are 85%, maximal oxygen therapy. I've intubated her. It's all gone well. The tube seems to have gone in okay. We've got an end tidal. SATs are 85. They're not coming up.
Right.
And it's been, I've given her a few breaths. I can see the end tidal. SATs are 85. They're not coming up. What's going through your mind, Amy?
Right. That's no good. So you've
No good.
you've
We weren't feeling
tried
good.
to intubate her to correct the hypoxia, but instead she hasn't gotten.
She's actually more
gotten better.
hypoxic
Actually, she's
now.
deteriorated.
Yeah.
Okay.
Yeah.
So in this scenario, this is probably the only mnemonic that I'll ever remember. So the immediate thing I think of is dopes.
Yeah, dopes. Yeah.
Yeah.
So that went through my mind. I'm thinking dopes, which is well, let's go through dopes. So D for displaced tube.
Yep.
Yeah.
So whether the tube's gone down the right main bronchus or the tube is in the esophagus.
Yep.
Mhm.
O.
Yeah.
Obstructed tube.
Yep.
Yep. Okay.
So how are you gonna?
Suction the tube.
Okay.
P's a bit controversial, but some people will say, pulmonary or patient factors. So I was thinking pneumothorax.
Pneumothorax, or I guess if the just progression of the disease. So
okay, just
pneumonia, if it's
the pneumonia.
worse.
Yep. E is equipment, and S is breath stacking.
Yeah.
Yep. Okay. So that's all well and good. So I thought, hey, I'll call an X-ray. There's a delay to X-ray. They're 10 minutes away. So I grabbed the ultrasound machine. I think I'm clever.
Good.
I'm going to ultrasound. I'm going to have a look at the lung, and I have a look on the patient's left-hand side. There's absent lung sliding.
Right.
I look on the right side. There's normal lung sliding, and I'm thinking pneumothorax. But is that right? And is there a more systematic approach? I mean, if you have post-intubation hypoxia, do you do other things before you get to that?
Yeah.
Talk me through what you do.
So I guess if you're gonna follow a mnemonic, you should probably go from the top. So you want to, even before, you want to make sure there's no pneumothorax. You want to make sure the tube is actually in the right spot.
Well, how can you tell that on ultrasound?
So, well, you could ask for an X-ray, but even in our department where
it's 10 minutes away, they're not coming.
Even in our department where we've got really good access, it takes about 10 minutes. So you can just grab the ultrasound probe and just pop it on the neck. Have you ever seen that done before?
So I've heard about this.
Yeah.
So it looks kind of like this. Yeah.
Yeah,
so
that's right.
So this is what it looks like when you put the ultrasound on the neck.
Yeah.
And what are we seeing? Just talk me through.
So in a normal appearance, you just pop the linear probe just above the suprasternal notch here. Okay. In a transverse plane. In a normal ultrasound appearance of the airway, it should look like a rounded air-filled structure. So just one in the middle of the screen. Yep.
Which is what we're seeing here. Yeah. So that's the normal. Yep.
Yeah. So that's in a normal airway, or a normal with the endotracheal airway. And usually the esophagus is quite compressed and flattened, usually lying to the left of that. Okay. So you don't really see it. Whereas if you are concerned about an esophageal intubation, what you're going to see is two tracheas, or what looks like two tracheas. So two air-filled structures side by side, and then you know that the tube's in the wrong spot.
So what you're saying is if I've got it in the esophagus, I'm actually going to see two tubes.
Yeah.
Yeah. Okay. So that's pretty grossly, obviously abnormal. Right. So in the wrong spot, I've got two tubes. Otherwise, I'm just seeing the one tube.
Correct.
Yeah. Okay. So that's pretty straightforward. Does that take long?
No, probably about 10 seconds.
So within 10 seconds, I can work out whether I'm in the esophagus. But what about the lung stuff?
Yeah. So once you're happy with that, you're not in the esophagus, you move to the chest. So you would probably, you're concerned about the left-hand side of the chest in this.
Yeah, look, she looked like she had left side pneumonia.
Yeah.
But I'm also thinking, well, did I do a right main bronchus intubation?
Yeah.
And I've put the probe on the left, but I've seen no lung slide.
Right.
So I'm thinking pneumothorax. Yeah. How do I work that out? How do I work out pneumothorax from right main intubation from the pneumonia? Is there a way, or am I just, is it a dream?
Question. So yeah, you're right to go the left first. So apart from the lack of lung sliding, which could be a pneumothorax, there are other reasons why there couldn't be any pleural slide on that side. So and how to discriminate between the two, I would probably just put on an M mode to help me.
No, that's getting a bit technical.
Yeah.
So yeah, okay. So the M mode's going to help me work out whether it's pneumothorax or not. So if it was a pneumothorax, what's it going to look like? Let's have a look. So
as we can see here, it looks like a barcode. So instead of seeing that seashore sign where you see the speckled appearance in the bottom half of the screen, it looks like a stratosphere or a barcode sign, and that suggests that there's no pleural slide and it's a pneumothorax.
So I actually did that, but it wasn't that. It wasn't barcode. It was something else.
What did you see?
It was kind of, I don't know, it was sort of dashes.
Okay.
Yeah. What's that?
I think what you're referring to is probably a lung pulse.
Yeah. Okay.
So what lung pulse is, it happens when there's still opposition of the pleura, but there isn't any pleural sliding, and that occurs when there's like a motionless or a lung that's not being ventilated properly.
Right. So an under ventilated lung.
Yeah.
Yeah, right.
So instead of the barcode appearance, it's easier to see when you use M mode, but you often see these little vertical lines,
so
like
little
this.
interruptions like this.
Yeah.
Yeah. Okay.
And that's what you get when
So
you
that's what
see
I saw. That was it.
Okay, good.
So now what does that mean? So not pneumothorax.
Not pneumothorax.
No. Tubes in the right spot.
Mhm.
Yeah. So what am I down to then? What are the
So now you're down to either it's there's adhesion there caused by either lung collapse or pneumonia in that area.
And she's got pneumonia.
Yeah. So it could be that.
Yeah.
Or the other option is that of what you have gone down the right main bronchus.
Okay. All right. So what would you do from there?
So probably I would look at see how many centimeters at the lip the tube has.
Well, we were a bit excited because, you know, she was pretty unwell. So we're 24 centimeters at the lip.
Right. So what you could do in real time is just take the tube back a few centimeters and actually see if that pleural slide comes back. And
okay. So pull it back and it might change things. And if it changes things, then what's happened?
Yeah, they'd be happy that the tube's gone above the carina and you're probably good to go.
Okay, all right. So, and I think that's what happened in this case. So we actually just pulled it back. X-ray never came. We pulled it back. The appearance changed, and so turned out it was a right main bronchus intubation.
Right. Yeah.
If it was just the pneumonia, what would it look like?
You would probably look for other signs of pneumonia on that area. So as well as the pleura not sliding, you might have some B lines or consolidation that you can see. I'm not sure if that was the case in this patient.
There were some B lines, but you know, it was a bit above my pay grade, so I was just really, that was a bit hard for me.
Okay, fair enough.
But so the specific signs of pneumonia.
Yeah.
Thickened pleura.
Yeah. So you're thinking thickened or irregular pleura, lack of pleural sliding. You can get some subpleural consolidation as well, and a bit of fluid in between the pleura and the lung tissue. So very abnormal in that area, which suggests.
If I had spent the time, I might have seen it. So that's great. That actually makes it much clearer.
Yeah.
So just again, if you've got someone, you intubate them, they remain hypoxic, post-intubation hypoxia, you don't need to wait for the X-ray.
No,
you can solve it with ultrasound. So I'd start suprasternal notch just above it, and I'm looking to see whether the tube's in the right spot. So is a tube in the esophagus? We're going through the DOPES algorithm. Tube in the esophagus, suction the tube. That's okay. D is dealt with. P, I put the probe on. I look for lung slide. If there's normal lung slide, it's probably okay. Must have something else. Must be a equipment thing or a breath stacking thing.
Yeah.
But if I don't have lung slide, then I'm down to pneumothorax or another pulmonary problem, which might be the pneumonia, or I've done a right main bronchus intubation and I've got collapsed lung. Yep. So then I go to M mode. I look for a lung pulse, and if I've got no lung pulse, what does that mean again?
So the lung pulse is when there's a pleural movement in synchrony with the cardiac contractility. You can't get that when there's a pneumothorax.
No, okay.
So the presence of a lung point excludes a pneumothorax, but there might be one of those other pathologies.
So there wouldn't be a lung pulse if there was a pneumothorax.
Yeah.
But if there was a lung pulse, I've either got just the underlying pneumonia, which would have some other changes, or I'd have a collapse from the right main bronchus intubation. And in this case, it was a right main bronchus intubation. We pulled it back. We saw a dynamic change in ultrasound. Problem solved.
Didn't need an X-ray.
Yeah, didn't need an X-ray. Took a few minutes, get the SATs up, and we're good. So that's post-intubation hypoxia solved with ultrasound. Thanks, Amy. No worries.
Anytime.
Take a break.
See ya.